Morning, everyone. So for today we have heart failure, okay? And since we have heart failure and SOC for two classes, okay, I'll be covering the initial half of the heart failure today. We'll be covering the management part tomorrow. Okay. Okay. So what is heart failure? Okay. So in general, heart failure it is inability of the heart to pump out the blood. Okay. But whenever you are asked about the definition, then it is a clinical syndrome that occurs in a patient who because of some inherited or acquired abnormalities. Okay, there can be some problem which may be inherited or acquired, and there may be problem with the structure as well as the function of the heart, and it develops a constellation of clinical symptoms like dyspnea and fatigue and signs like edema and rales that leads to frequent hospitalization, poor quality of life, and shortened life expectancy. Okay, so there should be some problem which may be inherited or acquired. There should be problem which may be problem with the structure or function, and this will lead to development of different signs and symptoms of heart failure. Okay, so the epidemiology, the overall prevalence of heart failure in developed countries, it is 2%, but this prevalence, it increases with ages. Okay, so it is more common in patients who are elderly. Now we can see that if the prevalence, it is 6 to 10% in people who are 65 years and older. Okay, so this overall prevalence of heart failure, it is thought to be increasing because of current therapies for myocardial infarction, valvular heart diseases, and arrhythmias. Okay, so since the development of this therapies for myocardial infarction, valvular heart diseases, and arrhythmia, it has come. Okay, and it has been improved. Okay, the people, they are living longer, and this has led to increase in prevalence in the elderly people. Okay, so now we'll be talking about the classification of heart failure. Okay, so depending on the ejection fraction. Okay, so it is divided into systolic heart failure and diastolic heart failure. First of all, you have to know what is the ejection fraction. Okay, so this term ejection fraction, it refers to the percentage of blood that's pumped out of the filling ventricle with each heartbeat. Okay, so what is the amount of blood before systole, and what is the amount of blood that is ejected out of the ventricle after the systole. Okay, so we have to know that and we can calculate it. Okay, so amount of blood pumped out of the ventricle with systole and total amount of blood in the ventricle before systole, this calculates the ejection fraction. Okay, so depending on the ejection fraction, if the patient has depressed ejection fraction, okay, so if the pumping capacity, it is impaired, then it is systolic failure, and if the ejection fraction, it is preserved, then that is diastolic failure. So in diastolic failure, the pumping capacity, it may not be impaired that much. Okay, so there is problem with the diastole or filling of the heart. Okay, it can again be divided into left heart failure, right heart failure, and biventricular failure. Okay, firstly, left heart failure. It is characterized by reduction in the left ventricular output and an increase in left atrial and pulmonary venous pressure. Okay, so sometimes it occurs suddenly, as in cases of myocardial infarction, where there will be rapid increase in left atrial pressure, which causes pulmonary edema. So if it occurs suddenly, okay, patient may present with acute pulmonary edema. And in other group of the patient, it may appear very gradually, okay, like in patient with valvular heart disease, like mitral stenosis. Okay, so this causes gradual increase in the atrial pressure with reflex pulmonary vasoconstriction. Okay, so this pulmonary vasoconstriction, it protects the patient from getting into pulmonary edema. But however, the resulting increase in pulmonary vascular resistance causes pulmonary hypertension, which impairs the right ventricular function. Okay, now right heart failure. Now, it is characterized by reduction in the right ventricular output and increase in the right atrial and systemic venous pressure. Okay? And the most common cause for this right heart failure, it is COPD, okay, chronic obstructive pulmonary diseases, chronic lung diseases, pulmonary embolism, and pulmonary valvular stenosis. Okay, so there is other term called biventricular failure. Okay, so this is other type of heart failure where both sides of the heart are affected. So both the ventricle may be affected because of the disease process itself, like in cases of dilated cardiomyopathy. We've seen that in dilated cardiomyopathy, mostly the left ventricle is involved, but it can involve right ventricle as well. Okay, or it may be as a result of ischemic heart disease involving both left and the right ventricle. And it may be because of the disease process in the left heart leading to chronic elevation of the right atrial pressure causing pulmonary hypertension, which leads to right heart failure. Okay, so it may involve both the ventricle at the same time with one disease, or it may have some diseases which is affecting one ventricle, like left ventricle, causing pulmonary hypertension and right heart failure, okay, involving both the right and the left ventricle. Now you have to know about the stages of heart failure also. Okay, so that was the classification. Okay, classification according to the ejection fraction, it is divided into systolic and diastolic, and according to the ventricle involved, it can be divided into left ventricular failure, right heart failure, or biventricular failure. Now, stages, we have 4 stages of heart failure. Stage A, B, C, and D. Okay, stage A includes all the patients who are at risk of developing heart failure but do not have any structural heart disease and symptoms of heart failure. Okay, so under stage A are included all the patients who are at risk of developing heart failure only. They do not have any structural abnormalities, they do not have any functional abnormalities, and they do not have any signs and symptoms of heart failure. Like for example, patients who are diabetic, who are hypertensive. Okay, so these patients who are diabetic and hypertensive only, okay, without any ischemic heart disease or dilated cardiomyopathy or any other structural heart disease. Okay, so these are the patients who are under stage A because they have the risk of developing heart failure, but they do not have any structural abnormalities and they do not have any signs and symptoms of heart failure. Now, stage B includes all the patients who do have structural heart disease but do not have any symptoms of heart failure. Okay, so this may be regarded as the patient who have compensated heart failure. Okay, so stage B includes patient with previous myocardial infarction and asymptomatic LV dysfunction. Okay, the patient of MI at the acute stage may be having symptoms of heart failure, but with treatment they may remain asymptomatic for prolonged period of time if they receive treatment early, and if the myocardial infarction is not involving a large part of the myocardium. Okay, so under stage B are included all the patients who have structural heart disease but without any symptoms of heart failure. Now, stage C includes the patient with structural heart disease with symptoms of heart failure. Okay, so patient with myocardial infarction, previous myocardial infarction with dyspnea and fatigue are grouped under stage C. Okay, so if the patient of previous MI they do not have any symptom, then it is under stage B, and if they have symptoms, then it is stage C. Now, stage D includes all the patient with refractory heart failure requiring special intervention, like for example, patient who are refractory to treatment of heart failure, waiting for cardiac transplant. Okay, so these are the patients who have structural heart disease, who have signs and symptoms of heart failure, who are getting treatment for heart failure, but they are refractory to treatment. That means even with treatment, the patient they are not getting well, so they are the patient who are the candidate for cardiac transplant. Okay, so stage D includes all the patients who have structural heart disease symptoms, and refractory to treatment. What are the etiologies then? Okay, so etiology, it may be caused by reduced ventricular contractility, like in cases of myocarditis, myocardial infarction, and cardiomyopathies. Or it may be because of ventricular outflow obstruction, like in cases of pressure overload, like hypertension, aortic stenosis, pulmonary hypertension, and pulmonary stenosis. Or it may be because of ventricular inflow obstruction, like in cases of mitral stenosis and tricuspid stenosis. Or it may be because of ventricular overload, like in cases of ventricular septal defect, atrial septal defect, and increased metabolic demand, like in cases of high output status, pregnancy, high grade fever. Maybe because of arrhythmias like atrial and ventricular arrhythmias, atrial fibrillation, complete heart block, tachycardia, okay? Or it may be diastole because of diastolic dysfunction, constrictive pericarditis, restrictive cardiomyopathy, left ventricular hypertrophy or fibrosis, and cardiac tamponade. Okay, so these were the etiologies, but this coronary artery disease, it accounts for around 60 to 75% of heart failure. And hypertension contributes to the development of heart failure in 75% of the patient. And in 20 to 30% of the cases of heart failure with depressed ejection fraction, the etiology, it may not be known. Okay, and in developing countries like ours, okay, so this rheumatic heart disease, it remains the major cause of heart failure in young people. Okay, so as we have already discussed, heart failure, it is more common in elderly people. It is less common in young people, but in countries, developing countries, underdeveloped countries like ours, okay, since there is still prevalence of this rheumatic heart disease is not so low, okay, so we are quite often getting patient of rheumatic heart diseases which who present with heart failure. Okay, and the prognosis, despite advances in evaluation and management of patient with heart failure, it has very poor prognosis. Okay, so 30 to 40% of the patient die within 1 year of diagnosis, and around 70% of the patient die within 5 years of diagnosis of heart failure. Okay, now we have to know this functional status, or also called NYHA functional classification. Okay, NYHA, New York Heart Association functional classification. This is important. Okay, so this is important for your bedside as well as for the management of heart failure. So you have to know it. Okay, so this is very important. So I'm telling it again. Okay, so this classification, NYHA functional classification, it is very important. So it it divides the patient of heart failure into four classes. Okay, so the four classes includes class 1, 2, 3, and 4. 1 includes all the patient with no limitation of physical activity and no symptoms with ordinary exertion. Okay, so the patient who do not have any limitation of the physical activity and who do not have any symptoms with ordinary exertion, they are included in class 1. Class 2 includes all the patients who have slight limitation of physical activity. Okay, and in these patients, ordinary activity causes symptoms. And class 3 includes all the patients who have marked limitation of the physical activity and less than ordinary activity causes symptoms. These are the patients who do not have any symptoms at rest. Now, class 4 includes all the patients who are not able to carry out any physical activities without any discomfort. And these are the patients who have symptoms even at rest. Okay, so you have to know this. Okay, so NYHA to classify shortness of breath if it is because of cardiovascular problem, and to plan for the treatment of heart failure as well. Okay, so this is important predictor of patient outcome. Okay, patient with symptoms at rest, that is NYHA functional class 4, have 30 to 70 8% annual mortality rate, and patients with symptoms with moderate activity, that is NYHA function class 2, have annual mortality of 5 to 10%. Now we'll be starting with the pathogenesis. Okay, so this heart failure, it may be viewed as a progressive disorder that is initiated after an index event. Okay, so there should be index event. Okay, so this index event, it may be damage in the heart muscle. Okay, so it may cause damage in the heart muscle with resultant loss of functioning cardiac myocytes, or it may disrupt the ability of the myocardium to generate force, thereby preventing the heart from contracting normally. Okay. So what is this index event then? So this may be abrupt on onset, like in cases of myocardial infarction. Okay, so myocardial infarction takes place, which acts as the index event, and because of some other changes that occurs in the myocardium, it causes heart failure. Or it may have a gradual or insidious onset, like in cases of hemodynamic pressure or volume overload. Okay, different valvular diseases. Or it may be hereditary, as in cases of many of the genetic cardiomyopathies. Okay, so what may be the index event? This produces a decline in the pumping capacity of the heart. Okay, so the after the index event, there is initial decline in the pumping capacity of the heart, and after there is decline, variety of compensatory mechanism are activated. Okay, so adrenergic nervous system, renin, angiotensin, aldosterone system, cytokinin system, they all come into play, and these systems are able to restore the cardiovascular function to a normal hemostatic ranges, with the result that the patient remains asymptomatic. So with these compensatory mechanisms, the patient may remain asymptomatic for prolonged period of time, varying period of time. Okay, but with time, the sustained activation of these system can lead to secondary in-organ damage within the ventricle. Okay, and this leads to worsening left ventricular remodeling. Now, I think we have come across this term remodeling. Okay, can you tell me what is remodeling? Any one of you? Last time also we discussed about this remodeling. Anyone? Do you know the term remodeling? Anyone? What is happening here? What's the problem here? I don't know. I can't see any one of you. Okay. Abhishek Sharma, what is remodeling? Okay. So remodeling, it is okay. So it is the changes that occurs in the heart. Okay, it may be the changes in the size, shape, structure, or function of the heart. Okay, so as a result of some injury to the heart muscles. Okay, so this is the left ventricular remodeling and subsequent cardiac decompensation, and this leads to development of symptomatic heart failure. Okay, so again the same thing, index event occurs. Okay, and the ejection fraction, it starts to decline, but compensatory mechanisms come into play so as to preserve the ejection fraction. But by that time, secondary damages are occurring. This develops symptoms in a patient in few years of time. Okay, so the pathogenesis, again to summarize. Okay, so due to some index event, there will be myocardial fibrosis or myocyte loss. This causes reduced cardiac output. Okay, So the ventricular dysfunction will be there, and decreased cardiac output will be there. Okay, so this activates the sympathetic nervous system and renin, angiotensin, aldosterone system, vasopressin system, endothelin system. Okay, so in cases of normal heart, okay, this supports the cardiac function, but in patient who has impaired ventricular function, okay, so this increases the afterload as well as the preload. Okay, so because of this neurohumoral activation, there will be vasoconstriction, which increases the afterload. Okay, and this increases the blood pressure and cardiac output, and it again damages the myocytes or the myocardium. Okay. Again, with the activation of the neurohumoral system, okay, there will be sodium and water retention. There will be increased intravascular volume, which leads to increase in preload as well, and increased blood pressure and cardiac output. This again leads to a myocardial injury. Okay, so this preload, so I think you all know about the preload. It is the volume and pressure of blood in the ventricle at the end of diastole. Okay. So afterload, it is the volume and pressure of the blood in the ventricle during the systole. Okay. So increase in afterload, increase in preload, it um, increases the cardiac load. Okay. So this again hampers the cardiac function. So clinical features or the clinical assessment. Okay. So whenever the patient has heart failure, okay, it doesn't mean that the patient will always present with acute features of acute heart failure. Okay, so it may occur in suddenly, as in patient with myocardial infarction, where the patient may present with signs and symptoms of acute left ventricular failure, but it may also occur very gradually, like in cases of valvular heart disease. Okay, but whenever there is gradual impairment of cardiac function, okay, several compensatory mechanisms takes place, and the patient may not have overt heart failure. These are the patients who have compensated heart failure. Okay, so they may have impaired cardiac function because of compensatory mechanisms. Okay, so the signs of and symptoms of heart failure may not be there. This is called compensated heart failure. Okay, so this compensated heart failure, if the patient has, there will be impaired cardiac function, and the patient will have adaptive changes which prevents the development of overt signs and symptoms of heart failure. Okay, and in these patients who have compensated heart failure, okay, so a minor event such as intercurrent infection, development of atrial fibrillation may precipitate overt or acute heart failure. Okay, so these patients may be asymptomatic for a prolonged period of time, but even with the minor triggers or minor event, okay, like intercurrent infection anywhere in the body, or development of different arrhythmias, okay, or even development of fever, development of anemia, can cause or precipitate the heart failure, and patient may present with acute heart failure. There is other term called acute and chronic heart failure. Okay, so acute heart failure occurs either de novo or as an acutely compensated episode on a background of chronic heart failure. So patient may have clinical features of chronic heart failure for a long period of time, but because of some decompensated state, okay, the patient may present with acute features of acute heart failure, that is acute and chronic heart failure. Okay, so what are the precipitating factors, okay, which may precipitate or aggravate heart failure in patient who has pre-existing heart disease? Okay, so these may be patient with chronic heart failure or compensated heart failure. Okay, so a patient who has chronic heart failure or compensated heart failure may present with acute left ventricular failure if the patient has these precipitating factors. Okay, so it may be myocardial infarction or ischemia, intercurrent infection. Okay, so infection anywhere, pneumonia, urinary tract infection, enteric fever. It can precipitate or aggravate the heart failure. heart failure. Okay, arrhythmias, different ventricular and atrial arrhythmias, inappropriate reduction of the therapy. Okay, so you are giving patient treatment for heart failure. You think the patient has improved, or himself or thinks that the patient has improved. Patient may decrease the medicine by himself or herself. That may be the cause for this signs and symptoms of heart failure in these patients, or administration of drug with negative inotropic effect like beta blockers, or patient who are getting fluid retaining drug has fluid retaining properties like NSAIDs, glucocorticoids, or patient who has pulmonary embolism, or the patient are in condition associated with increased metabolic demand like pregnancy, thyrotoxicosis, and anemia, and patient who are getting IV fluids and who are fluid. So if the patient has acute left heart failure, then what are these clinical features? Okay, the signs: patient presents with sudden onset of dyspnea at rest that rapidly progresses to acute respiratory distress. Patient may have orthopnea. Okay, the patient may also have prostration. And symptoms in illness of the patient, it will be very much agitated. The patient will be very pale and clammy, very cold. The pulse, it may be very rapid, and sometimes it may be bradycardia. Okay, and there can be excessive tachycardia as well. And these may be the precipitating factor for acute episode of heart failure. Okay, different arrhythmias, the brady and tachyarrhythmias. And blood pressure, it is usually on the higher side, but if it is normal or if it is low, we have to think whether the patient has cardiogenic shock. Okay, and JBP, it will be elevated and is associated with fluid overload or right heart failure. Now, what are the symptoms? Okay, so the when we are examining the patient, okay, so doing the cardiovascular examination, okay, so cardiac epics in acute failure, there will be no time for ventricular dilatation, and there will be no change in the place, or the no change epics or the mitral area. Okay, and in cases of chronic heart failure only, there will be cardiomegaly and the ventricular dilatation takes place and the apex will be shifted outward and downward. But if it is acute heart failure, there won't be any displacement of the apex. And when we are auscultating, okay, so we may be able to hear the murmur of the ventricular or the septal rupture, or we may be able to hear gallop rhythm. Gallop rhythm. Okay, any one of you, do you know about gallop rhythm? Anyone?
Horse riding like
Can you
sound.
hear? Okay, horse riding like sound. Okay, so what is the difference between the normal heart sound and the gallop rhythm?
S3 art sound is heard.
Okay, so if it is triple gallop rhythm, okay, so generally what happens is normally we have normal heart sound S1 and S2. Okay, so it sounds like lub dub. Okay, and if the patient has gallop rhythm, the patient may have third heart sound or fourth heart sound, or sometimes there may be both third and the fourth heart sound. Okay, so if both third and the fourth heart sound are there, then that is called quadruple gallop. Okay, and if the patient has only third or fourth heart sound, then it is called triple gallop rhythm. Okay, and sometimes if the patient has both third and the fourth heart sound, and if the patient has tachycardia along with third and the fourth heart sound, okay, there will be overlapping of the third and the fourth, and that is called summation gallop. Okay, so you have got the gallop rhythm. Okay, with triple gallop rhythm, quadruple gallop rhythm, and summation gallop rhythm. Okay, so these are the things you may get in a patient who has heart failure. Okay, And generally, since a patient of this left heart failure, they will have S3. S3 is more common. Okay, so the triple gallop rhythm, it is common in these patients. Okay, and when you are auscultating the chest, okay, so this was regarding the cardiac auscultation, and in auscultation of the chest, in the long basis, you may be able to hear the crepitations. Okay, so it is consistent with pulmonary edema. So if the patient has acute and chronic heart failure, the patient will have additional features of long-standing heart failure. For example, a patient who has mitral stenosis, okay, so the patient may have the shortness of breath for prolonged period of time. But if the patient presents with acute pulmonary edema, okay, the patient will have features of mitral stenosis as well as features of acute left heart failure. Okay, so in these patients, we have to check and identify the potential precipitating factors. Now, chronic heart failure. A patient with chronic heart failure may have relapsing and remitting courses. Okay, so they will have periods of stability and episodes of decompensation leading to worsening of the symptom. Okay, and the clinical pictures in these patients depends on the nature of the underlying heart disease, type of heart failure that has evoked, and the humoral changes that has developed. Okay, so low cardiac output. Okay, so there will be low cardiac output as well in patient who has heart failure. Okay, so this is responsible for fatigue and poor tolerances. Okay, so this is generally there because the heart has to maintain the perfusion to the vital organs. Okay, so the blood flow is diverted away from the skeletal muscle, and this causes fatigue and weakness. Along with that, there will be cold periphery, blood pressure will be low, and the poor renal perfusion can lead to oliguria and uremia. Now, there is a term called cardiac cachexia. Okay, so a patient who has chronic heart failure, so they are often associated with marked weight loss. Okay, it is often associated with marked weight loss. Okay, so it is generally caused by combination of anorexia, impaired absorption due to GI congestion, poor tissue perfusion due to low cardiac output, and skeletal muscle atrophy due to immobility. Okay, so as we know that there will be GI congestion, okay, gastrointestinal congestion. Okay, so in these patients who has heart failure, so during the acute episodes, it is better to give IV drugs in these patients because of the congestion in the gastrointestinal tract. Okay, so there may be impaired absorption of the food as well as the impaired absorption of the drug. Okay, so it is better to give IV drugs to these patients who have acute heart failure. Okay, so this is the diagram showing the difference that we get in patient who has right heart failure and the left heart failure. Okay, so if the patient has left heart failure, the JBP, it will be raised, but it will be more raised in right heart failure. Pulmonary edema is more common in left heart failure. Cardiomegaly is more common in left heart failure. Patient may also present with pleural effusion. There can be pitting edema, but pitting edema, it is more common in right heart failure. Along with that, the patient also has ascites and organomegaly, mainly hepatomegaly. But you see, all the patient who has this pitting edema, it may not be due to cardiac cause. Okay, so differential diagnosis of peripheral edema, it can be cardiac failure, right, or combined left and right heart failure, that is biventricular failure, pericardial constriction, cardiomyopathy, chronic venous insufficiency like varicose vein, hypoalbuminemia like in cases of nephrotic syndrome, liver diseases, protein losing enteropathies. Okay, and it may be because of some drugs like which causes sodium retention, like like NSAIDs, or which causes increased capillary permeability like nifedipine and amlodipine. And it may be idiopathic, which is more common in women than in men, and it may be because of chronic lymphatic obstruction. Okay, so these are the differential diagnosis of peripheral edema. Now, what are the complications? Okay, so the most important complications includes renal failure. Okay, so renal failure is there generally because of the poor renal perfusion, or it may be exacerbated by the use of different drugs like ACE inhibitors, ARBs, and Lasix. Okay. Along with that, the patient may also have different electrolyte imbalances like hypokalemia, hyperkalemia, hypernatremia. Okay. So hyperkalemia, it is generally because of use of different drugs like ACE inhibitors, ARBs, and potassium sparing diuretics. Well, whereas the patient may also have hypokalemia, and it is generally because of impaired aldosterone metabolism, leading to hepatic congestion, and it may be because of activation of the renin angiotensin aldosterone system, or it may be because of use of drug, mainly the potassium using diuretics like furosemide. And patient may also have hyponatremia. So it may be because of diuretic use, or it may be because of water retention. Okay. Along with that, the patient may also have increased tendency for thromboembolic phenomena. Okay, so since the cardiac function is impaired, there is more chances of getting thromboembolism, and there is also chances of getting different kinds of arrhythmias. Okay, ventricular arrhythmias, sometimes atrial arrhythmias, and there may be sudden death, and it is generally because of ventricular fibrillation. Okay, so this was regarding the complications. Now the investigations. So we have to do the routine investigations first. So complete blood count. It helps us to check for presence of anemia, polycythemia, renal function test to check for complications like renal failure, urine analysis should also be done. Okay, liver function test, blood sugar, fasting lipid profile, thyroid function test. These are the routine laboratory tests that can be done. Okay. Now, this chest X-ray, it is one of the important investigation, and it should be performed in all cases. Um, and there may be different abnormalities. Okay, so there may be changes in the cardiac size and shape. Okay, there can be cardiomegaly, and the shape of the heart, it may be changed. Okay, there may be abnormal distension or dilatation of the pulmonary veins, in mainly in the upper lobe. Okay, and the prominent vascularity may be there in the lungs. Okay, so these are just to show different changes in the chest X-ray in patient who has heart failure. Okay, and there will be appearance of curly B lines as well. Okay, so because of the interstitial edema that occurs in a patient who has heart failure, there will be thickened interlobular lobular septum, and there will be dilatation of the lymphatics. Okay, so this leads to horizontal lines. Okay, so these are called the curly B lines. These are mainly seen on the base of the lung. Okay, so fluid in the lung fissure, curly B lines, prominent upper lobe pulmonary arteries, and fluid in the lung interstitium, cardiomegaly, pleural effusion. Okay, so these are all the changes that occurs in a patient who, in chest X-ray of a patient who has heart failure. So the other investigations include ECG. Okay, so ECG, it may be important to detect the index event like myocardial infarction, or there may be the changes of different valvular heart disease like mitral stenosis, aortic regurgitation. Okay, But more uh, specific structural abnormalities we can see with the help of echocardiography, where we can see the size of the left ventricle, function of the left ventricle, calculating the ejection fraction, valvular lesion, if any, we can see, and if there is any regional wall motion abnormality uh, due to ischemic heart disease, that also we can see with the help of echocardiography. Sometimes there may be role of MRI to see for left ventricular mass and volume, and we can also see different cardiac biomarkers. Okay, so B type natriuretic peptide, N terminal probe, BNP. Okay, so these are released from the failing heart, and these are the sensitive markers of heart failure and depressed ejection fraction. Along with that, troponin T, troponin I can also be done if we suspect that the patient has myocardial infarction. Now, differential diagnosis includes renal failure and acute respiratory distress syndrome, because in both the condition the patient presents with edema and dyspnea, okay, orthopnea, PND. This is regarding the first half of the class. Okay.